You're listening to Medscape's In Discussion series on chronic obstructive pulmonary disease, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Leah Witt. Dr. Witt is a geriatrician and pulmonologist at the University of California, San Francisco. At UCSF, she is also the Pulmonary Associate Chief for Ambulatory Affairs, a coach for the Pulmonary and Critical Care Medicine Fellowship, and a passionate advocate for improving the care of older adults with chronic lung disease. Dr. Witt is an associate editor, producer, and sometimes co-host with The Curbsiders, a popular internal medicine podcast where she's covered topics on chronic lung disease, geriatrics, and gender equity. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Leah Witt. Welcome to Season 1 of the Medscape In Discussion Chronic Obstructive Pulmonary Disease podcast series. Today, we're talking about the diagnosis and management of COPD. COPD is the most common chronic lung disease in the world. Global prevalence is about 10%, and its prevalence is only expected to rise because the population is aging and risk factors like tobacco and biomass pollution persist. Among adults 50 and over, COPD is one of the top 3 causes of death worldwide, with higher death rates in low and middle income countries. Today, I'm delighted to welcome today's expert guest, Dr. Stephanie Christenson. Dr. Christenson is an associate professor at the University of California, San Francisco in the Division of Pulmonary Critical Care, Allergy, and Sleep Medicine. She cares for patients in the outpatient general pulmonary clinic and also attends on the inpatient pulmonary consult service. She is a COPD and asthma clinical and genomics researcher, and she's focused on understanding the heterogeneity of airway disease, which will be the topic of today's discussion. Finally, she and I both hail from Wisconsin, so I'm really excited to kick off our first podcast episode with a fellow Midwesterner. Welcome to the Medscape In Discussion podcast, Stephanie.
Thank you, Leah.
I wanted to start the podcast episode by getting to know you a little bit outside of medicine, because we know that you're an expert researcher and clinician, but what is on your mind outside of medicine, like a hobby, piece of pop culture, something like that?
I've got a big yard, so I usually do a lot of gardening, but California's had a lot of storms. So my gardening has kind of devolved into picking up a lot of sticks and throwing them for the dog.
Yeah.
That's been what I've been doing outside of medicine. What about you?
Yeah, there are trees down everywhere right now. So baking's my number one hobby, and I am trying to perfect my royal icing technique. The real way is to use egg whites, which just sounds kind of gross to use raw egg whites in icing. So I've been using like egg replacement and meringue powder, but I tried to have an elaborate decoration this weekend, and unfortunately I'll just kind of like melt it together like a snowman or something. So
maybe it still tastes good.
It still tasted good. It was really good. Well, thank you so much for joining us. Let's dive in. We have a case, and I want to talk today about your approach to diagnosing COPD and your initial steps in management. So let's start with the case, and then I'll dive into my questions.
Great.
So this is a case based on an amalgamation of patients that we've seen in clinical practice. No one in particular, but calling this patient Mr. Rivera. He's a 78-year-old man who has a chronic productive cough. He comes to be evaluated in the pulmonary clinic. He was recently hospitalized for influenza. He says that every year for the past 5 years, when he gets a viral illness, he has a really prolonged cough. He's sick longer than his family members, and he often gets antibiotics. He started smoking when he was 20. He stopped 3 years ago, and he smoked 1 pack a day for 55 years. He lives with his wife. He was grocery shopping, but she just had to take over the grocery shopping because he becomes too short of breath when carrying the groceries. And then his other medical problems include cardiovascular disease. He had an MI 10 years ago and diabetes. So I think this is a typical patient that we see in the pulmonary clinic. And I'm wondering, how would you approach this patient, and what are the things on your mind?
Sure. I think you're right. To me, this sounds like a pretty typical patient. We have them come into us after being hospitalized for influenza, and whether that's actually an influenza pneumonia or actually potentially compounded by a COPD exacerbation in an undiagnosed COPD patient is potentially what we're looking into. And I'll kind of go into the COPD diagnostic criteria since that's what we're really focusing on today. So certainly I'm going to be getting, this is a pulmonologist's office, so I'm going to be getting spirometry first, because with COPD, the diagnostic criteria, at least currently, are that you need to have a fixed defect. Kind of how that's diagnosed as fixed defect, whether you're using a 70% gold criteria or lower limit of normal based on how some people do it. It's a little bit of a debate, but if we're seeing a fixed defect, that is where I'm starting to think about a COPD diagnosis. So that's at least how I would start. And then you'd potentially go on and now we're talking about symptoms and exacerbations, and that's going to help me figure out how I'm going to classify and treat you. Is that kind of how you approach the patient as well?
Yeah, definitely. I feel like his history is screaming
Right.
COPD, but I think I would also be thinking, is there anything else? Yeah, I think you definitely want to be confident in the diagnosis with spirometry. And is there anything else going on? I guess he's got a cardiovascular history. That's where the exam helps, like is he in heart failure, things like that. But the history here was pretty straightforward for COPD. It's interesting to me, the diagnostic criteria for COPD. So the GOLDS is very clear. They want there to be a reduced ratio below 0.7 post-bronchodilator. And I think their rationale for that is really interesting because they want the spirometry to be available and easy to interpret no matter the resources available. So spirometry is a pretty cheap and easy thing to get no matter where you are. But if we start looking at like GLI and looking at the equations that use Z-scores and lower limit of normal, so that might help a little bit with the underdiagnosis and overdiagnosis problem, overdiagnosis in older populations, under and younger, but probably harder to get if you're in a lower resource setting.
Overall, COPD is very underdiagnosed. So I'm going to really be thinking about, do you need treatment, especially in a patient like this, where they're potentially having exacerbations and a lot of symptoms, even if I'm considering, is this actually, are you kind of on the cusp? Because the exacerbations have such bad outcomes. I do think either way, I'm kind of trying to make sure that if I'm using lower limit of normal, if I'm using fixed ratio, that if I do see a fixed defect, that I'm really thinking about, would you benefit from particularly our inhaled therapies? Because we really want to try to prevent future events.
And are you imaging on the first visit? It sounds like maybe he's out of his exacerbation or his influenza, whether or not it was a pneumonia. Are you imaging him on the first visit? And then if so, what are you doing?
Not necessarily. I will say oftentimes these patients meet criteria for getting low dose CT scans anyway. And so I will be doing a CT scan for that. And so sometimes that information can be helpful if I see emphysema, particularly in some of these kind of more borderline patients where maybe they're a little bit borderline. Do they really have COPD? Maybe they've got some longstanding asthma. And how am I going to go about treating you? Is the inhaled corticosteroid more important, or are the LABA long-acting beta agonist or LAMA long-acting antimuscarinic therapies kind of more important? So I might be kind of thinking about some of those nuances, but if I'm seeing somebody that looks really like this, where I'm, it's looking a little slam dunk. If we have a fixed defect, I may not need that CT scan, but I may be doing it anyway for cancer screening. What about you? Similar?
I think so. Yeah. And he was just hospitalized. Maybe he already has something that we can look at. So let's continue the case and then we can decide, is our diagnosis done? Are we done? So we order the spirometry and we decided to order spirometry with a diffusing capacity. His FEV1 is 60% predicted. His FEV1 to FVC ratio post-bronchodilator is 65%. And then his diffusing capacity is 48% predicted. What do you think of those PFTs and anything else you would do before, I guess, you move to your management?
Well, I think you kind of have brought this up before. So we've got a fixed defect. It certainly looks like we've got COPD. I would probably be looking at the flow volume loops as well, just to see, okay, well, do those look curvilinear? Are there nuances there? But then looking at the DLCO, that could certainly be down because of emphysema. And so that's maybe another piece of the puzzle. Since he's got cardiovascular disease, I may actually be a little interested in seeing what that CT scan looks like too, because I would like to have an explanation for that low DLCO. Is it emphysema or is it potentially something else given his other comorbidities, just to make sure we're not missing something, or that, he was just recently hospitalized. Obviously blood clots are important, but if I don't see emphysema on that CT scan, then it might make me see that low DLCO as a red flag. Is there something else going on? But those PFTs would certainly all be very consistent with a COPD diagnosis. But as we're kind of rounding out the patient and thinking about them as a whole, just ensuring that we're not missing something as well.
Great. So I wanted to ask you about disease heterogeneity, which is one of the things that you're an expert in. What does that mean? What does disease heterogeneity mean? And how does that affect how you parse out the disease subtype and management and things like that?
Sure. So I would say that I think of disease heterogeneity in a couple different ways. One is clinical heterogeneity. And, the GOLD report has really kind of gotten at that with the treatable traits algorithm, where we think about symptoms, we think about exacerbations, but I'm also thinking about clinical heterogeneity in other forms. Like some patients are more frail and more prone to things like pneumonias, which might make me think of them a little differently in how I treat them. Some patients have cardiovascular disease, so I want to make sure that I'm thinking about other systemic diseases, cardiovascular disease, depression and anxiety being huge comorbidities, sleep apnea. So I might be thinking about some of this other clinical heterogeneity as well as heterogeneity of the disease itself. So including exacerbations and symptoms, emphysema. So emphysema, chronic bronchitis, the pink puffer blue bloater that we normally thought of, but then there's actually a lot more clinical heterogeneity beyond that. And then I also may think of them based on biologic heterogeneity. Now, I do my research on this, but I think the big thing that we think about as far as biologic heterogeneity in COPD is that we've started thinking about eosinophils as being a marker of a patient who may have more type 2 or eosinophilic inflammation that might benefit from other therapies. And right now, that therapy would be inhaled steroids. So I think of it kind of clinically and biologically, and how might a patient benefit from our therapies based on that heterogeneity.
I really love that approach. I guess I never thought of disease heterogeneity as including the comorbidities. So that's a really interesting approach, and certainly affects your choice of medications. Right. Even outside of like comorbid asthma or
right.
Like
so
that.
Really thinking of it, really thinking of these patients as a whole and realizing what we can do for them with some of our medications, but also what we can do for them by treating some of their other comorbidities or making sure we're helping with their exercise capacity, et cetera, which may actually help them a lot more than just throwing an extra inhaler at them. So I think we just want to make sure that we're thinking of them as a whole.
Okay, great. So on the first visit, or I guess after you got the PFTs, you're sure it's COPD. Are you ordering a serum eosinophil count, or maybe you're just doing a look back to see if he's had an eosinophil count or any other blood tests?
I usually do look at eosinophils, particularly in a patient like this where, hey, maybe he was just hospitalized for an exacerbation, particularly since hospitalized exacerbations have a much higher mortality rate. I call them like heart attack of the lung. So I'm certainly going to check an eosinophil count in this type of patient, although I do check it in a lot of my patients. And the reason for that is that if it's high, I'm really going to want to think about triple therapy for that patient, meaning keeping them on inhaled steroids, a LABA, long-acting beta agonist, and a LAMA, long-acting antimuscarinic. Even if it's low and I'm not too concerned about keeping them on inhaled steroids, I will probably keep it on because there's some secondary analyses data showing potential improved mortality with triple therapy compared to the dual therapies. However, certainly if you're eosinophil high, I'm really thinking about it.
And I think we would call him stage E.
Correct.
Stage E. Yeah. So that just changed in the GOLD guidelines. That used to be C and D. So do you know why they did that?
The major reason that they did that was, first of all, there are actually not a ton of patients, although I certainly see them in my practice, that are exacerbation prone and have no symptoms. It's just not a huge group. So, usually you're symptomatic or you're symptomatic and exacerbation prone. There are some people who, are those like one-offs that they're fine and then they all of a sudden get an exacerbation, but it's not super common. And either way, the outcomes with exacerbations are bad enough that symptoms or no symptoms, we want to ensure that you're on the maximal therapy to prevent future exacerbations. It's based on the history. It almost makes it a little more difficult because you're like, they went from A, B, C, D to A, B, E. What? But if you really, we're just trying to change it to 3 categories. You either have exacerbations or you don't. And then if you don't, do you have symptoms? And if not, then you're in that first A category.
Got it. Okay. So he would maybe get triple therapy, depends on his EOs or how sick he is. Or the other option would be a LAMA.
Correct. Yeah.
Combination.
Yeah. So that's how I would treat him. And like I said, it's a little nuanced with the ICS LABA/LAMA, whether you definitely want to keep that on versus LABA/LAMA. The guidelines currently would suggest, certainly if he has high eosinophils, and potentially taking it off if they're low. But I would say that's a little bit more nuanced, that I would probably keep it on unless he was showing me that there was a good reason to take them off, like he's getting bacterial pneumonias or really frail and I'm very worried about keeping an inhaled steroid on.
And then when would you think about adjunctive therapy? Like I've started patients on azithromycin or roflumilast, or what other therapies are you thinking about if he's still exacerbating in spite of your best efforts?
That's a very good question. So the first thing I'm thinking about before I do any of those, and I know that you probably are thinking about this too, is he adherent to the medications that he's currently on? How is the inhaler technique? And sometimes I'm checking it or having one of our respiratory therapists check it because there's a lot of ways you can get that wrong. I'm really thinking about pulmonary rehab because I do think that can be one of the most beneficial things that we can do. And then in subsets of people, I might use azithromycin or roflumilast. The big problems with those being, I'm a little bit worried in these exacerbation prone patients about giving them a chronic antibiotic that they could become resistant to. Roflumilast can have a lot of GI side effects, so not everybody tolerates it. But I think the more patients you try in some of these, you do find that there is a subset of people that it's incredibly helpful for. I do encourage other providers to kind of learn from us that it can really actually help some patients really drastically, but I'm not going to necessarily keep it on if it's not helping you. If you're not feeling better from it, or we're still continuing to have bad symptoms and exacerbation.
Yeah, you hit on something so important, medication adherence, and then there's technique issues and cost issues. We're going to dedicate a whole episode to this because I think that's the number one reason why a medication in COPD is not working, because the cost, maybe they haven't hit their deductible and they can't afford the $500 in January.
Yes. So frustrating and so important.
The last thing I wanted to ask you about, you already talked a little bit about pulmonary rehab and managing comorbidities, but how do you see your role as a pulmonologist in thinking about comorbidities? What do you feel is our role as pulmonologists?
I mean, I'm certainly kind of checking that box when I see my patients, hopefully every time, although I must admit that I can't, we don't have time every single time, but we want to make sure that our patients are getting vaccinations. And I think otherwise we need to really be working as team players with the primary care physicians, with cardiologists, potentially psychiatrists, sleep experts, really working to understand, you're at increased risk for cardiovascular disease, depression, anxiety, obesity, sleep apnea. And so I really want to be kind of going through those boxes because some of the reasons that patients may not be doing well may be because of these comorbidities, and working in conjunction with COPD. Certainly we know that the feeling of dyspnea is worse if you are also feeling depressed or anxious, and maybe some of those things are going to make depression and anxiety worse. So we really want to be working with our primary care physicians, with other providers, to ensure that those issues are really addressed as well. That's how I think of myself as a COPD expert, that we're really thinking about that patient as a whole.
That is so important. And I, as a geriatrician, feel like the beyond approach is so important for managing chronic diseases or chronic lung diseases. So think that's all we have time for. Any final key points that you want to leave our listeners with?
I mean, I think you kind of brought it up at the end. What was so important to me really in this discussion is just thinking of these patients as a whole and thinking about, first of all, that there is a lot that we can do for these patients to make them feel better, for their dyspnea to feel better, and for their symptoms to feel better, but that we also want to make sure that they understand that exacerbations are really bad for you and that a lot of what we do is really preventative. And so we're going to try to prevent you from feeling worse or from potentially even dying by using some of these therapies. So thinking of those kind of pieces, the comorbidities, the symptom control, and the exacerbation control as being really key pieces.
And I'm taking away that you taught us that exacerbation is a heart attack of the lung, which I love. And disease heterogeneity is more than just the biologic heterogeneity of, like, should we think about an ICS, but also we're thinking about their comorbidities and heterogeneity. So thank you so much for that. Well, let me summarize. Today, we talked to COPD expert Dr. Christenson about pearls for diagnosis, special considerations with deciding which inhaler to use, and how we risk stratify based on gold group and initial management. This was such a rich discussion. Thank you so much for joining us. Take a moment to download the Medscape app to listen and subscribe to this series and others. This is Dr. Leah Witt for the Medscape in Discussion COPD podcast.
Thanks for listening to Medscape's In Discussion Chronic Obstructive Pulmonary Disease podcast series with our host, Dr. Leah Witt. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on chronic obstructive pulmonary disease.